Hi, my name is Dr. Sophia Deben. I'm an orthopedic foot and ankle surgeon, and I practice general and foot and ankle orthopedic surgery. I wanted to spend a little bit of time today talking about acute management of extremity injuries or orthopedic injuries. Obviously, that can go from anywhere from a contusion where someone has a trip and fall or a box falls on them. It could be a sprain, it could be a fracture, and it can even be the pain and swelling that occurs after a surgery. There's really 4 key parts to appropriately managing that first 2-week period or the acute inflammatory phase after an injury or a surgery. And those are having the right diagnosis. Number 2, appropriately managing the soft tissues. Having adequate and appropriate pain management, which is what I consider multimodal pain management. And then the 4th piece is when and how to begin motion. In the setting of an outpatient injury that is relatively low severity, having the correct diagnosis is very important. Obviously, people trip and fall all of the time, and in the injured worker population, there can sometimes be excess or too much pain that is due to secondary gain, right? They're trying to get a little bit of time off of work or what have you. But there are also quite a few people that have undiagnosed injuries that get missed over a period of time. Many of the carriers use a generalized primary care location of service where the injured worker is being seen by a primary care internist and not necessarily an orthopedic surgeon. And so not uncommonly, I see patients 2, 4, 6, and 8 weeks after what was considered a sprain or a contusion, but later on we find out that it's a fracture or something more severe. And so having the appropriate diagnosis is critical. And so I really enjoy and recommend having an MRI to give a tissue level, tissue specific diagnosis, both for the carrier and also for the patient. It is very easy for me to say, look, your MRI only shows this, this, and this. I know that in 4 or 6 or 8 weeks, the ligament or the tendon is going to heal, and that you should be 80% better in 2 to 3 months, versus, oh my goodness, you're having all of this pain, and by the way, you have this small fracture. This is now going to take 4 to 6 months. Because some of the cases do turn litigious, I also feel that obtaining an MRI within 2 to 4 weeks of the time of the injury is also a very good starting place for everyone to begin really on the care of this particular injury, so that everyone is clear on what the tissue level injuries are, and that can very easily sort of predict what the length of time of treatment and care is. It's very helpful when I have a very clear diagnosis to tell the patient how long it's going to take them to get better. Many patients now are aware that MRIs do exist, and many of them express frustration in not having had one as part of their care. And I think that sometimes that sort of little bit of doubt that an MRI wasn't obtained in their case can sometimes fuel some unnecessary sort of symptomatology that can very easily and quickly be resolved with a very simple, appropriate study. So having the right diagnosis is critical in managing acute pain and in the acute inflammatory phase. Number 2 is managing the soft tissues. There's the idea in children's sort of psychology of the dandelion, the tulip, and the orchid. Dandelions are sort of weeds. They can grow anywhere. They're not particularly sensitive to their environment. Orchids is quite the opposite. They are very sensitive to their environment. Every patient is a little bit different. Some patients don't experience a lot of pain, they don't experience a lot of swelling, and we can relatively quickly start moving them and have them walking and getting back to work in a short period of time with really minimal intervention, minimal pain medication. Other patients are a little bit more like an orchid. Perhaps they have a lot more anxiety. Perhaps they have problems with swelling. Middle-aged females who are considered to be obese by BMI will have a lot more swelling, and that swelling is very painful. And so managing the soft tissue in the acute period is very important. So if someone has a lot of swelling and bruising, immobilizing them in a boot or a cast, having them go home and stay home and getting them a leg elevator, and literally explaining to them that they have to be home with their foot up all of the time, except for when they're eating or using the restroom, is going to do a very quick job of getting rid of that acute inflammation and helping to transitioning them into the second part, which is collagen inflammation or healing phase, which we'll talk about later. But soft tissue rest is critical. And oftentimes when I recommend that a patient after something like a sprain or a contusion be put into a cast or a boot, everyone sort of rolls their eyes and says, oh my gosh, it's gonna be 4 weeks, it's gonna take forever. No, there's nothing wrong with putting someone in a cast or a boot for 1 to 2 weeks and sending them home and really just shortening that period of acute inflammation, and then at the 1 to 2 week mark, transitioning them out of the cast or out of the boot into some gentle walking. And so managing that soft tissue with rest, ice, and inflammation when it's necessary. So if you happen to have an injured worker that is having a whole bunch of bruising and swelling, they're sending you pictures of this swelling that keeps happening, that's someone that needs to spend a period of time in elevation, rest, and soft tissue immobilization. The third thing is multimodal pain management. Again, in the dandelion patient, they may need a little bit of Motrin here or there at nighttime or maybe around the times of physical therapy. In the orchid patient, sometimes people will have a lot of anxiety, sometimes people will have nerve symptoms, creepy, crawly, burning feelings at night, patients that are describing inability to tolerate the sheets or the blankets on their foot. They have a nerve component to their pain that something like a narcotic or an anti-inflammatory is not going to address. People who are very nervous or anxious are afraid they're going to lose their job, they're afraid they're not going to get better, they're kind of lost in the system. Their anxiety level is also going to increase their overall feeling of pain. And so starting with an anti-inflammatory as a 24-hour day and night, obviously assuming that the patient isn't hypertensive or has renal disease, is a good starting point. Number two, if anyone's having cramping, spasm, or an anxious component to their pain, especially when it's related to long bones, contusions in the quadriceps muscle or back pain, short periods of muscle relaxing can also be very helpful in overall helping the system to return back to a state of pain-free sort of safety is the idea. It's not just that their pain is better, but overall they don't feel as traumatized from the experience. I have patients that do have anxiety disorders that come in that they are completely untreated, and I will sometimes place them on an anxiolytic for a few weeks so they can tolerate being home and recovering, whether it's postoperatively or freshly after an accident. Some patients become very depressed. They'll be in the office and they'll be crying for whatever reason. A short course of an antidepressant may not be a bad idea also to include. And then for the patients that do have the nerve symptoms, a Neurontin, even just 300 milligrams every night, can help with the nighttime pain, can help with the overall daytime pain. It is not addictive. And then patients who have had a history of drug use or drug abuse, I will oftentimes recommend a red light and or a cooling device that also inflates to help push some of the swelling out and address some of the pain without having to use a medication. And in patients who really have completely uncontrolled pain, and I think we all know, we've all seen them, I'm not afraid to use a little bit of tramadol, which is a very mild narcotic agonist. So it's not a narcotic, but it's similar to a narcotic. It's a controlled substance. But I will use it on a short period of time to help get them basically cooled down. We want patients swelling and acute pain to decrease so that we can actually start moving them and get them weight bearing. But if we don't actually get rid of their pain in that first period, that pain lingers and lingers and lingers, and it becomes a baseline that limits their ability to participate in therapy and limits their ability to return to work. And so my approach is to, from the get-go, really address all of the acute symptoms, because I know that they're going to go away in 1 to 2 to 3 weeks. And then finally, we want to start gentle progressive motion. Some people within 1 to 2 weeks after an ankle sprain are able to start very simple up and down, in and out. They don't have to go to physical therapy right off the bat if they're having a lot of pain, but we can get them used to the idea of gentle motion. I'll usually recommend 20 minutes, 2 to 3 times a day, for them to come out of their boot and just do some gentle motion to a pain tolerance of 2 to 3 out of 10. Usually when I institute that, by the time the physical therapy that was ordered has been set up, usually 2 weeks, that patient has already been used to exercising that ankle or that wrist or that shoulder by themselves, so that when they show up with a therapist, they can do more with a therapist. And so gentle progressive motion is something that we institute in order to get them back to a full range of motion, and then we start strengthening. And so initiating some form of home physical therapy, which is something that can very easily be taught to the patient, once their soft tissue has decreased in swelling, their pain has been controlled, is a very simple bridge that can both help the patient psychologically and physically prepare for maximal success with physical therapy. So again, make sure you have the right diagnosis. Make sure that for whatever soft tissue injury the patient is having, they are getting appropriate treatment, whether it be for spasm, nerve pain, excessive swelling, and then consider multimodal pain management to include an antidepressant, an anxiolytic, a nerve pain medicine, and or a mild narcotic, and then encourage gentle and early range of motion and early physical therapy that's gentle as you're transitioning out of that inflammatory period into the collagen healing or the recuperation period. Thank you so much.